This video, what I wanted to do is explain or answer the question, why do you take x-rays, or why do you x-ray as a chiropractor? This is one of the frequently asked questions we get asked in clinic. There's a number of different reasons, so I'm going to give you some examples, show you some before and after cases so you can actually see what we're looking for and why we do it. But it's interesting. I remember when I first started here, which was going on 11 years ago, one of the very first x-rays I took, this guy came in and I said to him, "Is there any chance you've been shot before?" And he's like, "Oh, yeah, 20 years ago." And he told me this story. He was mucking around as a kid. Apparently he had like a tin drum on a stick. He was hiding behind a damn wall. One of his friends was trying to shoot the drum whilst he moved it. Anyway, the bullets ricocheted off the drum into his chest. And apparently, according to him, it's lodged so close to an artery or something that it was too risky to take it out, so they left it in there. As you can see here, there's a little bullet sitting in there. This isn't actually the x-ray I took. 11 years ago, we didn't have a digital x-ray machine. We only had the analog one, which meant we processed them with wet film. But this is pretty much identical to what it looked like. So it's interesting because we often ask the question to patients, have you had any surgery? Have you had any injuries? Invariably, they say no. And then once we take an x-ray, there's screws or plates or something in there that they've forgotten about. So it happens. Having said that, that's not the reason we take x-rays. We're not normally looking for stray bullets, but from time to time they do come up. So from a medical point of view, there's a few reasons why we would take an x-ray. The obvious ones are after a trauma, so we're looking for a fracture. Otherwise, we could be looking for a pathology like an infection or a tumour, something of that nature. From a chiropractic standpoint, though, we also want to look a bit deeper. We're not just interested in ruling out some of those nasty things. We also want to see what the state of the spine is. So what's the alignment like? What's the movement like or the function like? And what's the age of the spine look like? Because just because you're 20 or 30 or 40, you could have the spine of a 50, 60, 70, 80-year-old. And all of that will make a difference in how we care for you, how we treat you, and the prognosis or the results that you can expect moving forward. So what we've got here, I wonder if I can make this full screen. Okay. So what we've got here is, these are x-rays I took 2 weeks ago. This on the left is the first one, on the right is the second one. And this is looking at somebody from back to front, and we're looking at their pelvis, which is this big thing just here. These are the hip bones on either side, and the spine. The blue line is your theoretical normal or your textbook normal. The red line's what this person's actually doing. Now notice, it doesn't take an Einstein to work out that one hip is actually lower than the other. In this instance, he's actually got a short leg. When measured, it came in at 10 mil. You can imagine in this instance, if he's got that sort of a discrepancy, he's going to have far more weight going through one leg than the other, which means he's much more likely for one hip joint to wear out than the other down the track. But it also means he's going to have more weight going through each joint within his spine on one side compared to the other. So he's more likely to get more muscle tension on that side, more wear and tear, earlier arthritis, and essentially pain. He's more likely to get pinched nerves and jammed up joints on one side than the other. So we could adjust him, we could treat him with exercise, with massage, with acupuncture, all these different things. But the pain is probably always going to return unless we actually correct this difference. So in this case, we gave him a 10 millimeter heel lift, and you can see the job that it's done. So these x-rays are literally taken moments apart. This one was taken, we measured it, we then gave him a heel lift, he stuck it in one shoe, and it's lifted it up. So in this case, and you can see the difference it's also had in the alignment of the spine. Straight away, that's going to start taking pressure off, relieve it, and give him a much more long-term solution. So this is one of the reasons we'll do it. So the question is, well, do you need an x-ray to tell this? Yes. If someone's laying on the table, I can definitely tell if one leg's shorter than the other because you can see it. Or if someone's standing there, you can see that their posture's off. Whether that's because they've actually got a short leg in terms of a true short leg or a functional short leg, which is they've just got muscle tension on one side, which causes the leg to contract, it's very hard to determine without an x-ray. And it's also hard to measure without an x-ray. It can be done, but it's not as accurate. This is by far and away the most accurate way to do it. And you can get immediate feedback once you put that lift in. So the next thing we want to do, I mentioned function. So we want to see how well the spine actually moves. In these two images, we've taken pictures of the same person. They're bending one way and then they're bending the other. And this is what we call a motion study. This image on the right is quite healthy. What we can see, these teardrop shapes in the center of the spine. There, if you run your hand down somebody's back, the bumps you feel when you run your hand down the center of their spine. So what we want to see is that each one of those rotates further across than the one below it. So notice how this one starts to rotate, this one starts to rotate further, and so on. That one is a really good example. So we want to see these actually spin to the side that you're bending. We also want to see that the disc pinches and gaps. So just in here should be more narrow, and over here it should be open. And that tells us that the disc is moving quite healthily. When we look at this picture, and the other thing you'll see is that there's just generally uniform movement throughout the whole bend. Notice here though, these two bones don't seem to move, and then all of a sudden you start to get a bit of a kink, and the movement's not as smooth looking. This is a problem. This one in particular. So notice how this disc or vertebrae is not tipping whatsoever. There's no pinching and gapping. That disc is fixed. So when she goes to bend that way, there's zero movement occurring in that joint. What that means is that she's got to make that movement up elsewhere, namely just here. So you can see this one's doing far more pinching and gapping and needing a much more distinct rotation just here, as the body is doing its best to actually make up or compensate for the lack of motion. You can kind of think of it like if you've got, there's 5 bones in your lower back. If you've got 5 guys all doing a job, digging a hole, and one of them takes a holiday, now you've got 4 guys doing the amount of work that 5 should be doing. So they're going to wear out soon. They're going to tire sooner. This is very similar. So one of the goals of care in this instance is we want to restore the function or get this joint moving properly and the disc moving properly, so that we give it relief and a lasting correction. Because this person, I can assure you, they can get massages, they can get adjusted, they can do all these things from time to time. They'll get relief, but the problem will return so long as that joint's stuck. And the benefit of doing these specific x-rays is, if need be, we can actually take a comparative x-ray or a second x-ray after a period of time, and we can see the change that's taken place in the spine. So you've got black and white results. Now this is a really cool set. So this is a lower back from the side. This is another common view that we take. And what you can see here is you've got a blue line, which is textbook normal, and a red line, which is what the person's doing. Now, bearing in mind, textbook normal doesn't mean that you must equal textbook. This is actually quite a healthy image. They're getting some narrowing of their disc just here, which means they probably have and will experience low back pain at some point in the future because it's going to narrow the space around the nerve just at the back. So that space there should ideally look more like these. And the gap between these two bones just here should be clear like these. Just tells us that there's some wear and tear going on. But nevertheless, your overall alignment is not too bad. Compare it to this one. Now this is a significant deviation from normal. What's happening here is this person's got to sway back. So this is their tailbone. This is their spine. This is what you'd call a slouch posture. So they're leaning back. And what that does is it puts more weight on the joints at the back of the spine as opposed to allowing the weight to naturally go through the disc at the front like it's designed to do. Now, what I've then done is found a similar x-ray of somebody who's about 20 years older. And so this person's 32, 33. This person's in their 50s. Now notice the amount of arthritis occurring through here. So you're getting these spurs on the front of the joints, particularly higher up that's a result of essentially being out of line and having incorrect weight transfer over a long period of time. So this person, 20 years, 30 years previously, would have looked something like this. If we can get this under control and correct this and get this back toward this, we're going to slow down or normalize the rate of wear and tear in this back so that it doesn't end up looking like this so quickly. And obviously what that's going to mean is you've got more movement, more function, a better quality of life. But without an x-ray, there's no way of knowing how much or if any arthritis there actually is. There's no way of completely identifying this posture. I've taken digital postural analysis, which is a photo, and we analyze it on a computer, and I've compared it to these x-rays. And we do this for everyone, by the way. So if we take an x-ray of you, we also take your digital posture. There are times that they look completely different. So your posture, it's really hard to tell because you've got so much muscle and soft tissue on your body. It's really hard to say exactly what the spine's going to look like just by looking at you without it. And then the next question is, well, can't you feel it? Well, yeah, this spine is obviously going to feel more stiff to palpate and to test the joints than this one or even this one. But I can't feel those spurs. I can guess that they're there, but I don't know for sure, and I don't know exactly what level. Notice they're not at every single level. They're just at these. So that's going to change the way I deliver care. It's also going to change the prognosis of this person. So rather than me thinking I'm dealing with this, when I'm actually dealing with this, and I'll tell this person, hey, it's going to take 12 weeks to get over this and to start to make a change in this posture, I can tell this person, look, it's too far gone to correct your posture. This is what you can expect. We can expect pain relief, improvement in function. We can improve the posture, but it's never going to be fixed. So this is what you can expect moving forward. And if you don't do anything, this is what you can expect as well. So we can be far more, we just know what we're talking about because we can see it. This is somebody's neck. This is from the side. On the left, far left, this is a fairly normal neck. You've got a nice curve in there. The jaw's at the front just here. This is the back of the skull. And this middle one is what we call phase one. So the neck's now a reversed curve. It's gone out of line. If this doesn't get corrected, and it's not going to get corrected on its own, no amount of exercise will correct this. You need to adjust it, you need to put traction into it, and you need to do specific mirror image exercises to start to bring this back. There's an entire protocol to do this. But if we want to actually correct it, or if we leave it, there's obviously going to be more weight going through the front aspect of these joints than this one, particularly here and here. Now this one is another person, it's not the same person, but more advanced. Notice how the bone is starting to change shape right around that wear point. Same concept, they've got the reversal curve. That disc is starting to thin out. Now that is going to accelerate and pick up. So this is early onset osteoarthritis. That progresses and then ultimately you start to get these bigger spurs forming, and this person would continue and eventually it'd fuse. And I'll actually show you a really cool video, time-lapse video of what that looks like in a moment. So that's the postural aspect of the cervical x-ray or the neck x-ray that we're going to take. We also want to see what the function of the motion of that neck is like. So we do a similar motion study to the lower back. We have someone bend their head forward and then bend their head all the way back, and we're assessing motion. Now, when we do this, we use what's called a modified Penning's analysis. It's not going to mean too much to you, but essentially we're checking each segment or each vertebrae and how much movement it's getting compared to the one above it and below it. And it gives us really good information because we can see basically which vertebrae are doing all the work, which are not doing the work, and where we need to target our care. And just notice, so when this person tips their head backward, it increases that curve and the movement is fairly uniform. It looks quite good. When we look at this one, however, this person's bending their head forward. What we expect is that you get a nice smooth curve forward. Notice how this is remaining flat, so all the movement is occurring at the bottom. And notice there's also a little spur forming just here. It's no coincidence. It's because this joint is doing far more work than it's designed to do. So it's going to wear out sooner than the rest of them. So when we're targeting our care, we're actually not going to adjust this joint just here. we want to make sure that the joints above it, which aren't moving, start moving and start actually carrying some weight and start doing some work to take the strain off this guy. And that's going to make a big difference. It's going to relieve this person's neck pain, headaches, shoulder pain, pins and needles in the arms, these sort of symptoms. Okay, so I promised you I'd show you a video of what it all looks like. And this is it. So this is somebody's neck, and this is how it wears out over time. I'll just pause that there. They're starting off with the right curve. Now their jaw's just here. This is the back of their skull. What this is going to show you is what happens when the curve is lost. So this person will have a car accident or they'll have bad posture. Their neck flattens out. The weight causes the ligaments to start to deform. The neck starts to shift forward. Now notice you're also getting spurs starting to form at the lower aspect of these joints just here because they're carrying more weight. But you'll see them and they're going to start to bridge or fuse. See these discs are thinning out, rough edges, you're starting to fuse through here, through here, through here. All the while this is happening, those discs are drying out, this person's getting less and less movement, more and more pain, until ultimately these joints pretty much fuse up. That doesn't happen overnight. However, it is preventable, and that's the point. The only way we can know what's going on in your spine is if we can see it. So in answer to the question at the start, do you need x-rays? We don't know. We certainly don't x-ray everybody every time. But if we do recommend them, there's a very good reason. You know, and sometimes people come in and they're really keen just to get to work, and we advise against it, and sometimes people can get agitated because they just want to get cracked or they want that relief, and I understand. But if we take an x-ray, we need to review it. That's going to take us the night to do so. So we'll process them overnight, get their report back so we can get you in the next day and actually show you your x-rays and show you our findings. We'll put together a program to say, hey, this is what we've got to do to get this thing under control. This is what we've got to do to correct it. I'll never forget, years ago, my wife and I were really keen to go hang gliding. So I got online. It asked me questions like my height, my weight, booking details, all the rest of it. So I did that, paid for it, and it was 2 months out. We had to drive down to, I think it was called Hill 60 or something, down towards Wollongong or just past Wollongong. So driving from Bathurst, it's like a 4-hour drive. We're halfway down. And the guy rings me, he's like, oh, hey, so I'm really excited you're coming down today. Just want to check a few things. What do you weigh? I'm like, 95 kilos or whatever it was at the time, which I'd emailed him 2 months before. He's like, oh, mate, you're not going to be able to jump. You're not going to be able to hang glide. So I was annoyed because I was really looking forward to it for 2 months, and I'd given him my details 2 months previously. So I put a bit of pressure on him. I'm like, mate, I basically said that. He's like, oh, look, I really don't want to. We'll see what happens when you get here. So, and obviously my wife's next to me. She's nowhere near my weight, so she was cool. So we weren't turning back. So we went all the way down there. We get there, and he looks at me and he's like, look, you're quite fit, so I think we'll be all right. And I'm thinking, hell yeah, I want to do this. And I was so focused on just doing it, I didn't even stop to think about why he would hesitate taking me out. The second we jumped off the cliff, I found out because we dropped. We dropped like, I don't know, it felt like we dropped 50 meters. It was probably 20 meters in a split second. It just went woof. And then we're floating around there, and it's supposed to be peaceful and graceful and whatever. I don't buy it. It's terrifying, particularly when you're overweight. So this thing, every time a hang glider would go in front of us, we'd hit they call it wake, just like a boat. We'd hit it and we'd drop 10 meters, and it was terrifying. And then coming into land, it was really windy, just picked up, and the way it was, we had to go over a fence and over some trees and different things, and it was a bit awkward because we had to go from hill to hill, and so that meant that the air changed, and it was just super rough and super turbulent and fast. As we're going down, he's swearing. He's like, he's just yelling and hollering, saying how awesome he is because he's a daredevil, essentially, not in that sort of language. And I'm hanging on for grim life. Obviously, I survived and intact, but I'm never, ever doing that again. It was terrifying. I thought I was going to die. So the point is, I understand what it's like to really want to get in and do something. And I understand sometimes we think it's just red tape or, we know better. Well, let me assure you, in these instances when we want to get x-rays, there's very good reasons for it. And literally your health is on the line. We need to know what we're dealing with before we get to work. And this is one of the best ways we have of knowing that. So I hope this video was helpful. If you have any questions, obviously send me an email, call the office, more than happy to discuss it with you. And as always, there's no hard and fast rules, so we will discuss this in detail with you and come to the right decision for you. All you've got to do is discuss it with us. But I hope this was helpful.